I'm focusing my talk on weaning modes with a little bit more practical application and realizing that it is 3 o'clock in the afternoon and the lights have just gone dim and everybody's a little bit probably overwhelmed from Paolo's amazing talk with lots of physiology and lots of physics. So I'm trying to keep mine a little bit more lighter and a little bit more clinically applied, I think. So just in terms of my disclosures, I conducted a randomized controlled trial of SmartCare, which is on Dräger ventilators. Back in 2007 was when we finished the trial. It's part of my PhD. Dräger Medical at the time gave me a box of mints. I still have that box of mints. I found them when I moved to London. So my other disclosures, so here I am giving a talk for Dräger Medical UK, so they have paid for me to fly from Canada, and we're also going to have some food and some nice wine. Those are my disclosures, my talk, so I'm all good with that, and I have no other relevant disclosures related to ventilator companies as yet. ResMed have just given me some money and some ventilators for a home ventilation trial. So what am I going to talk about today? So I want to just refresh our memories in terms of who we are weaning in our ICUs and talk a little bit about our different weaning styles, talk a little bit about pressure support weaning, use of spontaneous breathing trials and use of weaning protocols. And then I'm just going to talk a little bit on what we can use in terms of our closed loop and our proportional weaning modes. So we have SmartCare, we have adaptive support ventilation and now IntelliVent. We have proportional pressure support and PAV, and we also have NAVA as well. And I'll finish up with should we wean using non-invasive ventilation. So as I said, it is 5 minutes past 3. I want people to stand up if they use pressure support weaning as their primary mode of weaning. It'll make you feel better if you stand up. So the majority of the room is saying they are using pressure support weaning. So those people that have not stood up, what are you using? There's a group over here that didn't stand up. Is that because you don't wean patients from the ventilator, or I'm going to get ya? What's that?
We're veterinary surgeons.
You're veterinary surgeons. You don't wean your animals? No, you kill them, that's right. Over here, there's some people over here.
Modes that allow the patient proportionality.
Okay, some proportional modes, yep.
Of the flow time course of the breath.
Okay.
So a spontaneous breath. It's not a pressure breath.
Beautiful.
So that would be CPAP, or breathing on EPRD, which is CPAP.
Yeah, absolutely. Fantastic.
That's what I would do.
Okay. And what about spontaneous breathing trials? I know in the UK they're a little less prevalent than the North American setting. So who uses spontaneous breathing trials? Hands? Yes? Most? A little bit? Not so much? All right. Okay. That's the wake-up session. All right. So who are we weaning? So back in 2007 at a consensus conference that I had the absolute fortune to attend as I began my PhD on weaning for mechanical ventilation, the consensus paper that came out from that identified these 3 different groups of patients that we wean. We have our simple weaning, which basically are patients that don't need to be weaned at all, so they simply extubate very quickly after a spontaneous breathing trial. We have that more difficult category that maybe take 2 to 3 spontaneous breathing trials, but less than 7 days to wean them off the vent. This is not duration of ventilation, this is duration of weaning. And then we have the prolonged weaning group, which are taking a lot more than that. And I've spent the last few years of my career really focusing on those prolonged weaning group as I work with weaning centres both in Canada and here in London. And then we have the WIND criteria as well, which is relatively similar. They've got this group that have no weaning whatsoever. And again, they sort of have the short weaning, which is very easy, readily extubatable group. And then they have the difficult and prolonged again with a sort of 7-day sort of demarcation of weaning. So those are the patients that we're looking at. The thing about these definitions is they really don't focus on the progressive reduction in ventilatory support that we tend to refer to as our weaning modes. They really focus on the progression to extubation. And as you work with the more prolonged, the difficult and prolonged weaning group, then you come to realize that it's a lot more work that you need to do before you can get to that point. So in terms of weaning styles, when I first put these pictures on my slide, so I went and saw Rocket Man on Thursday night in Toronto, and I also had Freddie Mercury here. But then I was trying to think, I think those are both spontaneous breathing trial type sort of people. So I replaced a George Clooney with a more slowly progressive type of weaning style. So, as a refresher, what is pressure support ventilation? So the majority of you in this room said that you would use pressure support ventilation as part of your armory of weaning styles, right? So this is just a reminder of what it is, that it is this partial support mode. Obviously, it's allowing the patients to breathe spontaneously. However, it does not allow the patient to control the breath completely because we set a pressure target or limit. So every breath has to be delivered to that target or limit. And we also terminate the breath, or the ventilator terminates the breath, on a flow criteria. So you get a decaying flow, and whatever criteria, see the image on the slide there is set at 25% of maximal inspiratory flow. When the breath reaches that flow, it decays to that flow, then the patient is cycled into expiration. So it is very fixed in some ways, so the patient does not have control over the amount of pressure or the inspiratory time. And this can be very different to the neural drive of the patient and can result in problems. So again, there are problems with under and over assistance associated with pressure support that have been documented in the literature. We generally focus on we haven't given them enough, but we tend to not focus enough on we've given them too much. And so increasingly within the evidence base, we're seeing pictures that are focusing on too much tidal volume and too long a duration of inspiration, or potentially both. And these result in ventilator asynchrony because of this mismatch with neural inspiration. And it can also, these two excessive tidal volumes and excessive duration can result in diaphragm weakness. So you can be causing the same damage that we generally associate with control modes with pressure support ventilation. So what is a spontaneous breathing trial? So by definition, a spontaneous breathing trial is a focused assessment of the capacity to breathe without ventilator support. So again, it's focusing on that end product of moving the patient to extubation. So there has been work published previously, and Luigi highlighted a study that I'll also mention just briefly as well, in terms of thinking about the duration of a spontaneous breathing trial. So a few years ago, Andres Esteban's group demonstrated that you really only needed 30 minutes and that 2 hours was way too long. But again, it also probably depends on whether you're doing simple, difficult, or prolonged weaning patient populations. And then there are different alternatives in terms of the method. So you can take them off the vent and put them on a T-piece. You can apply low-level CPAP, or again, you can apply low-level pressure support. You could arguably apply some of the proportional modes that I'll talk about later in the talk during a spontaneous breathing trial, but I would say that that is not common practice. And so you apply this change, this assessment of extubation readiness, and obviously you monitor the patient to make sure they don't develop tachypnea, that they don't develop hypoxia and desaturate, that they are not hemodynamically compromised by this lower level support, and they're not resulting in increased work of breathing. So we're very, very simple, as I said, really on the end of the weaning. So this is a systematic review that was published by Karen Burns, who also works in Toronto and does a lot of work on the use of spontaneous breathing trials. And again, I apologize if it's a little bit blurry, but basically this is in her meta-analysis. You can see here that in these 11 trials that are comparing pressure support to T-piece, there is an indication that you should use pressure support as your spontaneous breathing trial. But again, we need to think about this. Are we talking about simple to wean, difficult to wean, prolonged weaning patient population? And a lot of the studies, again, that are we lumping or splitting, a lot of these studies are sort of lumpers in terms of getting the patients together. And then again, this most recent trial that Luigi highlighted in our session this morning, so this sort of has a large number of patients, so way bigger than any of the previous trials that have been conducted in this area. And again, it gives us an indication that a 30-minute pressure support SBT is preferable to a 2-hour TP's SBT, but as was mentioned this morning, why did they use 2 different time frames? Why did they not do a head-on in terms of the different methods? So those are pressure support ventilation, which I would say is the primary mode of weaning used internationally. Spontaneous breathing trials, and even though they're called, you would consider them potentially a different style of weaning, they still incorporate pressure support ventilation. So another style of weaning, just to highlight for you, is the use of weaning protocols. And so I put the weaning protocol slide in here because a lot of the automated weaning protocols, particularly SmartCare and the new Quick Wean on IntelliVent, really are an automated version of a paper, if you will, protocol. And so this systematic review published in Cochrane led by my good friend Brona Blackwood, now probably needs yet another update. It's trouble with doing a systematic review. So this Cochrane review identifies that there is potentially a benefit for using a weaning protocol, and as every weaning protocol study gets published, the benefit of using the protocol tends to get a little bit stronger. But again, here you can see that pressure support ventilation, so that style of ventilation that potentially locks patients into a set pressure and a set inspiratory time, features heavily in the weaning protocol literature as well. So moving on to automated and proportional weaning modes. What are we talking to? What are we referring to when we're talking about these? So who else in the room, just show of hands, don't need to stand up this time, uses any of the automated or proportional modes that I mentioned in my what I'm going to talk about slide? Nobody? Which I think the Dräger people would acknowledge is that there is poor penetration of the market of some of these things. So SmartCare, what is SmartCare? So SmartCare has been on the market for a numerous amount of years. So the original trial was led by Laurent Brochard. So he was part of the development team for the algorithm, and they published a trial that was conducted in 5 European centres and demonstrated that use of SmartCare reduced overall duration of weaning and ventilation. So what is it? So basically, SmartCare is an algorithm for using pressure support. As I said, it's an automated weaning protocol that enables a closed-loop management of pressure support. So it is a style of pressure support ventilation. And the aim of SmartCare is to keep or get a patient into a respiratory zone of comfort and maintain them in this respiratory zone of comfort, and then do a spontaneous breathing trial to identify whether the patient is ready for separation. So the respiratory zone of comfort, there's sort of things that you would not be surprised in seeing in terms of a normal respiratory rate, a tidal volume that is above the minimum threshold estimated for height, and an end tidal CO2 less than 55, or for COPD patients less than 65. And so this is averaged over 2 to 5 minutes. So this closed loop monitoring of these parameters dictates what SmartCare does in terms of manipulation of pressure support, both down for weaning, but also up again if the patient is deteriorating. And so this is what SmartCare looks like when it's up on the ventilator. And you can see here in this section here, there are the multiple diagnoses, the 8 different diagnoses that are made based on this ongoing monitoring of respiratory rate, tidal volume, and end tidal CO2. So a couple of systematic reviews have looked at the effect of SmartCare. So this one again, led by Karen in Toronto. So she looks specifically at automated versus non-automated weaning systems that are slightly different to the systematic review that I will show you. So she really focused on SmartCare. And again, you can see that in her systematic review, again published, we must have all been doing systematic reviews on weaning 4 years ago, she identified that using SmartCare decreased weaning time by just under 3 days, all right? So some good evidence to suggest that SmartCare is a useful tool to have in your weaning armory. And really it sort of works on the same principle as a protocol, except that you don't have to be the person that goes back and adjusts the ventilator for a protocol. The automation, the closed loop of it, does it itself. Here is another recently published paper that I think is quite a different use of SmartCare, looking at whether SmartCare is useful in terms of improving asynchronies by comparing in a crossover RCT SmartCare to conventional weaning in patients that were classed as difficult to wean. So remember, to get into the difficult wean category, you have to have failed a spontaneous breathing trial. As everybody now argues that if you're going to do a weaning study, you need patients that need weaning. And so really, those patients that don't fail a spontaneous breathing trial are not the ones you want in your study. So this is a small trial. As I said, it's a crossover trial, 30 patients, and they measured asynchrony indices. And so they demonstrated that there was a reduction in asynchrony with the use of SmartCare compared to usual weaning. And I've just brought up there in terms of an image of the different types of asynchronies. The 3 asynchronies that they saw in these patients were the ineffective triggering, where there's no patient response, the double cycling, where there's an additional breath, and then you've got the short cycling, where breath is delivered but it's terminated very quickly. So again, in this small exploratory study, they identified that SmartCare, and this is probably because it titrates in response to the individual patient, so it does change pressure support levels, albeit not breath by breath. So it does it every 2 to 4 minutes, not breath by breath, such as the proportional modes, but potentially is going to result in less asynchrony. So they hypothesized it was because of more pressure support variability and lower tidal volumes used when the patients were in SmartCare. So moving on to adaptive support ventilation and also IntelliVent. So IntelliVent is the most recent version of adaptive supportive ventilation, which now automates pretty much everything. So ASV started out with a clinician setting of a percent of minimum ventilation. So basically, you as a clinician are setting how much you want to support the ventilatory capacity of the patient. And so now IntelliVent, which is the next generation of this thinking and this software, now automates based on oxygen parameters, so on SpO2 and on end tidal CO2, and can basically automate the whole of the trajectory of the ventilatory course from intubation and fully controlled ventilation. It can flip the patient to spontaneous breathing, and it can also titrate pressure support. So a very sophisticated ventilator system. And so I've said that. And so the other thing that is now available on the IntelliVent is this Quick Wean program. So it's a little bit similar to the SmartCare in terms of it does these 3 phases of observation, where it's designed to basically reduce the ventilation, make sure the patient is stable within that lower level of ventilation, do a spontaneous breathing trial, and then recommend whether the patient is ready for discontinuation, or if it has had to abort the SBT, and then provides reasons as to why the patient failed SBT. Now, I don't think there has been any research conducted on this at all. It's relatively new, and you can see here that in terms of what IntelliVent Quick Wean can manipulate, it manipulates more than just pressure support. So it can also manipulate PEEP and manipulate FiO2, and does a little bit more monitoring than SmartCare can do. So I said very new and very little data telling us whether this is going to be a good tool in terms of how to wean our patients. So moving on to proportional modes. So proportional modes are different to SmartCare and IntelliVent because basically they are doing a breath by breath change of the support that the ventilator is providing based on patients' efforts. So we know that patients have a volume demand and they have a flow demand, and this is what proportional modes work on. So we have proportional pressure support on the Dräger ventilators, and so you can see here there is a requirement to set flow assist and volume assist. Proportional pressure support is based on PAV, so proportional assist ventilation, that has been around for a good 20 more years, but has not gained mainstream dominance within the market, and is now available as PAV Plus on the market in the Puritan Bennett ventilators. So this is proportional pressure support on the Dräger ventilators. As I said, you need to set a flow assist and you need to set a volume assist. I had a wee chat to them today. It was, again, looking into the literature in terms of directions of how to select these settings is a little bit complicated and a little bit of guesswork. So you are going to have to think about what you need to set your flow assist to overcome resistance and what you need to set your volume assist to overcome compliance. It's a mode that could also be used in non-invasive ventilation as well. And so when I spoke to the reps this morning, they recommend starting at 4 and 4 and then titrating up or down. I found a case study that said to start at 8 and 8 and then titrate up and down. But again, so there's not a lot of good science to tell us how to do this, but it uses this breath by breath delivery of support, which may arguably be better. It enables more variability to the support that is given than the fixed level of support that is in pressure support ventilation. So this is the competitor on the market that has come from the original PAV and is now PAV Plus. And so they, again, it's very, very similar in terms of the science behind it, measurement, resistance and compliance. But on these ventilators, what you're requested to set is a % support, which again, when you try and think about that, what does that really mean? So generally, what you're setting is the proportion of support that you want to give the patient in their spontaneous breaths. So we generally begin at around 80%, and then we can wean down after that. Now again, guidance in terms of how to wean PAV Plus is extremely limited, and again would be dependent on if you're in the difficult to prolonged weaning group of patients. We've done some work looking at using PAV Plus in the very, very prolonged weaning patient population, and it can be very tricky, and again it's very dependent on assessing patient parameters to determine where you should move your PAV down and what sort of speed and what you can do on a daily basis. But you can, in principle, use it similarly to a trach mask trial sort of weaning, so the progressive trach mask trial that we tend to prefer in the really difficult prolonged weaning patient population. So you can give them short periods of much lower level support. So rather than a decremental wean down by 10% per day, you can give them sort of spontaneous breathing trial sprints on, say, potentially 40% support or 35% support, and see how they're tolerating those. So again, the science in terms of the clinical application of these modes is relatively limited, but there has been some systematic review work that I'll look at. So the other mode that is similar in terms of it being a proportional assist mode is NAVA. So again, all these different modes are available on different ventilators, and so I think some of the reason why there is lack of uptake in the clinical setting is you have to have the right ventilator to be able to use some of these modes. If you don't have a ventilator, you just can't use them. NAVA came out with Mackay and now Dräger with, again, as Paolo mentioned, you need another nasogastric catheter to be able to deliver NAVA. And so you can see in the graphic there, so a nasogastric catheter that has sensing that basically monitors and senses the electrical activity of the diaphragm, so the EDI, and delivers proportional support based on this sensing of the diaphragm activity. So the theory behind it is that obviously we can't stick our probes into people's brains to sense that neural inspiratory drive and inspiratory cycling, but we can use the diaphragm as the closest proxy. And this is what NAVA does. And you can see in the image there, you can see that it monitors the electrical activity of the diaphragm and will deliver the inspiratory support in relation to this. There are issues in terms of the catheter and placements and signal, which again I think has made it maybe not as mainstream as originally was hoped to be. So as I said, there are a few systematic reviews that are starting to put some of this data for us. So this review published just last year looked at 15 studies, 10 of NAVA, 4 of PAV, so not PAV plus. I think these are older studies with traditional PAV, 1 of both. And here you can see, again, there's only 3 studies here, but you can see that there's some suggestion that these proportional modes may help reduce weaning failure. But again, they're small studies. We don't have 1,000-patient studies, God bless us, in these modes. And they will be still challenging to do in terms of large international studies. Here as well, here's just looking at the ventilation duration. And again, you can see that there is some indication that using proportional modes will reduce duration of ventilation for us. But again, the data is not strong, even though we do have some trials. This is just a study of NAVA that I would like to highlight. It's a feasibility study, but it was a trial. It was conducted here in London by a colleague of mine. And here again, we have some indication that use of NAVA, and in this study is different to the other studies. This study used NAVA from the beginning of ventilation. So rather than switching to NAVA when the clinical team has decided that the patient is ready to be weaned, this study put patients on NAVA very early in the course of ventilation. And again, the thinking behind that is that if these proportional modes do reduce asynchronies, and there's quite a large body of literature saying now that they do reduce asynchrony, then starting it early is going to be more beneficial than only starting it when we get to weaning. So I said I also conducted a systematic review that brought many of these different modes together, so both the stepwise reduction automated systems and the proportional ones. And again, bringing these studies together, it suggests that these modes do reduce ventilation and weaning duration. So finishing off in my last few minutes before I take questions, is there a role for early non-invasive ventilation for weaning? So extubating patients for weaning. So why might this be a good thing to do? So we do know that the pathophysiology of weaning failure is an imbalance between load and capacity, along with an abnormal cardiovascular response and an ability to increase cardiac output during the weaning process, and ischemia and increased preload and afterload in the left ventricle. So non-invasive ventilation, it decreases work of breathing by decreasing an elevated inspiratory threshold load, increases alveolar ventilation, increases intrathoracic pressure. So So the physiology is there. So this is the trial that Luigi did not highlight in the top 5 trials, because we're both investigators on the trial. So this is another trial that came out last year, the BREATHE study. And so again, what we wanted to do in this trial, so this trial was led by Gavin Perkins, was take a heterogeneous group of ICU patients, so not just the COPD patients. So all of us in this room would say NIV for COPD is a good thing. And also, again, we wanted to make sure we had those difficult to wean patients, so they had to fail an SBT. This is how we worked out that in many ICUs in the UK, they don't do a formal SBT process. We had to teach them that as well. And so the intervention was early extubation to non-invasive ventilation, but the clinician could decide that, and then weaning of the IPAP of the NIV versus a protocolized pressure support weaning with decremental pressure support every 2 hours based on standard criteria in terms of are they tolerating it. And again, an SBT for extubation readiness. So this trial, its primary outcome was time to randomization, from randomization to successful liberation from all forms of mechanical ventilation, because obviously it's going to be shorter in the early extubation group. But you can see here by the Kaplan-Meier curve that there was no difference in the primary outcome of this trial. However, they did identify potentially a reduced use of antibiotics for respiratory infections. So this was how we identified VAP in a very pragmatic trial. There were no differences in reintubation or tracheostomy rates or mortality. And there was also a reduction in use of sedation with the use of non-invasive weaning. And having just been to the American Delirium Society meeting, we know that we want to reduce sedation for other reasons than just getting them off the ventilator with increased risk of delirium. And this trial was very rapidly followed up by a systematic review and a Bayesian meta-analysis, and I'm not David Harrison, and he did an amazing job of describing Bayesian statistics, and that was fantastic. But here, this is the systematic view that incorporates the BREATHE trial into the previous studies. And this systematic review in conclusion suggests that use of NIV for weaning does decrease hospital mortality and incidence of VAP and decrease length of ICU stay, and is particularly beneficial as a strategy in patients with COPD. So in conclusion, where are we now? So despite all this advances in ventilator technology that's based on a huge amount of physiology and physics and very, very good science, as we've indicated in this room, pressure support ventilation continues to be the most common weaning mode used. We know that we should potentially use a spontaneous breathing trial to determine whether we get our patients off the ventilator, and we can use probably pressure support ventilation for this. Arguably, we could use some proportional modes. I think that there is increased evidence that protocols and automated weaning modes do work. They do reduce ventilation duration, and they do increase weaning success. And we have an increasing body of evidence that tells us that proportional modes decrease asynchrony, and they may decrease ventilation duration and weaning success compared to pressure support ventilation. But as I pointed out, most of these studies are small. They could be considered pilot studies. We do need some bigger trials. And I think we've now got really quite good evidence that tells us that getting that tube out and getting them onto non-invasive ventilation might be better than manipulating the ventilator, particularly for our COPD patients. So thank you, and happy to take questions.
Thank you very much for this really clear overview of sort of weaning modes and SBTs. I'm sure there'll be questions in the room. Any questions? Any sort of things that you do normally? Anything you'd like to contribute? Any comments? Paolo.
Thank you so much for your always brilliant overview. 2 questions for you. Regarding the SBT trial with pressure support, we also use almost pressure support. For how long? In the study that was mentioned was 30 minutes. What's your recommendation? And second, can you have a comment about the tracheostomy? which may be part of the weaning process, and what's your experience on that? You do early, late. We know the results of the study, but what's your experience in your country? And you have some categories of patients that you behave differently. I mean, what about tracheostomy and weaning?
Right, so the first question is, what about duration of spontaneous breathing trials? So I think the evidence says 30 minutes is fine. The reality is, if you're in a different professional setting where that requires another member of the staff to be in attendance for 30 minutes, what happens in reality is the spontaneous breathing trial is started, that person then moves away and then generally comes back within an hour. So I think in reality, most spontaneous breathing trials tend to be more like an hour in terms of clinical reality, but they don't need to be. But then I also don't think we titrate our duration of our spontaneous breathing trials on simple, prolonged, difficult weaning. We do the same on everybody, right? So that 30 minutes means, okay, I can extubate that patient, fantastic. And then 30 minutes on somebody who's way up the trajectory, it's just telling us they've failed the spontaneous breathing trial and doesn't give us an awful lot more information, I think. In terms of tracheostomy, so coming from Toronto with Niall Ferguson and Damon Scales, in Toronto, they've moved to a more later tracheostomy model. I would say the average duration of tracheostomy now, time to tracheostomy, is anything from 10 to 21 days. In the weaning centre that we have in Toronto, we only take trached patients, but length of stay before admission to transfer to a specialised weaning centre is a minimum of 21 days. And in reality, it can be 3 months before they get there. So, you know, there's the evidence for tracheostomy is potentially leave it a bit longer these days. But then there is the other patient aspects of tracheostomy in terms of communication as well.
In neuro patients, do we have some in Toronto? I don't know if you are working in that setting, but in neuro patients, do you have some the same or?
So I don't work with NAVA in trach patients, and I don't know that they use it in trach,
neuro patients.
Oh, in neuro patients.
So I mean, brain injury or stroke or hemorrhage. I don't know if you have experience on that in Toronto, but if you know something about it.
So they still delay. Yeah. Yeah.
Very good. Any other questions? Yeah, there's one over there.
Thanks very much for a very comprehensive review. What's your experience of extubating patients onto high-flow nasal oxygen?
So I think we saw that in an earlier presentation. That is becoming increasingly more common practice. I think we've had the studies that have suggested that it's a beneficial practice and can potentially prevent some weaning failure. But I think that we're slipping into, let's just put it on everybody because patients love it, it's easy, we have this perception that it's cheap. So I think we're seeing increasingly use of high flow on patients who probably don't need it.
Yeah, I mean, even patients with COPD,
Yeah.
the interface is a lot easier.
It is, right? So we're probably seeing a downturn in use of extubation to NIV and an uptake in extubation to high flow. Yeah.
That's excellent. Any other thoughts? Any other questions? Well, there's one over there. Thank you. Yeah, no, we can hear you.
I wonder what your thoughts are, talking a lot about purely SBTs as a prognosticator for successful extubation, but other methods we might have, diagnostics on the ventilator, considerations generally for the patient outside of an SBT, or whether that alone should be considered.
Well, I think what happens in reality is that clinicians have those parameters of an SBT in their heads when you're walking around doing rounds, assessing whether that patient is either ready to commence weaning, whatever that might look like, ready for extubation. Even if you don't do that formalized SBT, you still have those same parameters in your head, right? Because I come originally, obviously, from the accent from the Australian context, Australia, New Zealand, where again, when people were talking about SBTs, well, everyone's like, we don't do that. We basically put them on, low-level pressure support. You have your clinical judgment of, they're not tachypneic, they're not hypoxic, they're cardiovascularly stable. We've had them on a minimum level for, I don't know, however long we've had them on, it's fine. Let's extubate them. So I think it's a gestalt more than anything. That's why I said it's a weaning style, whether you do a progressive and get to a low level and at some point in the day you make that decision, or whether you do this focused assessment, is more of a style thing that I do think has some international perspectives that shaped it that way. Does that answer your question?
Were you referring specifically to weaning indices like P01,
And,
NIF?
yeah, RSBIs
That's
and
RSBIs.
so forth, and yeah.
Yeah.
Absolutely. And as you probably know, like the evidence base for weaning predictors, I mean, this was a whole great huge chunk of my PhD, right? It was, the evidence base is very large, and we have no one predictor that has very good sensitivity and specificity. I think, the RSBI has been one of them that tends to come across more standardly, and that's now reproduced on some of the ventilators that we have. So again, as our ventilators get more sophisticated, they have more of these parameters for us to look at. And some of the units that I work with, they document it every 2 hours religiously, and others totally ignore it. So, no.
Yes, that's very important. So it's a question on the back.
Just to go further with that, what do you feel the places or the correlation with occlusion pressure measurement?
So, in terms of weaning, so are you talking about in terms of determining the time to start considering the weaning process, or the time to start extubation? So obviously, it is an indicator that if it's improving, that obviously the patient is improving and they've got better drive to breathe, but you can use that at 2 time points. So what would you say? So I think you're going to demonstrate some of this in your hands-on this evening, is that right?
I think clinicians are starting to use it more, to follow it as a trend, but I don't have any clinical reports from them on what the correlation between weaning success, but as another parameter to follow to look at workup breathing.
Yeah.
So you're talking about sort of serial measurements of P01 over time to predict, So there is some literature about that.
Yeah, there is, absolutely. But I don't know that many people do it clinically.
So we, in a way, we do it because you can measure it every 10, 15 minutes using the automated occlusion. And it's quite useful to see whether the patient is over-supported, under-supported. But we don't do it systematically, as you're saying, just as a ad hoc, Anything else about part? Yeah.
We measure P01 a fair bit of time. I like it for effort, and I think it's a good surrogate for that. And we sometimes find that the rapid shallow breathing index can be falsely low, meaning if a patient has high effort, so there's no perfection in any of this. But you can see people that are really pulling quite hard numerically, because it's more objective than saying, look at that patient breathing, because we don't do that. So numbers, and there's a composite that people have written about, which is taking that, multiplying that by the RISB, and should be less than 300. So it's trying to look at workup breathing slightly differently. We know that when the load goes up, typically your volumes go down and your rate goes up, typically.
Yeah.
But if someone is capable of generating large tidal volume, they may still have a load, but they're able to, especially if you're using, I would say, pressure support, because the patient can get into the elastic support. The resistive element is finished as soon as the patient makes an effort, but if they continue their breath, they can pressurize their lungs, and so they can get some volume more than you would expect.
Yeah,
So that's another thing you can try. I mean, we've looked at that somewhat. There's
Can I
nothing
ask-
that's perfect.
Can I
no.
ask you a question? Because
Yes.
obviously the RISB is critically dependent, or the threshold is critically dependent on the level of support, the level of PEEP. How do you adjust your RISB sort of threshold?
This is not going to be very popular, but I don't believe in pressure support at
No,
all,
I mean,
including
pressure.
for the. We use 0 because actually the number that was validated, if you want to use the 105, was done on T-piece.
Yeah.
So I'm not really sure, and I think, if the patient is really ready for extubation, the flow is low, so the patient's resistive element is really not significant.
Mm-hmm.
When we use automatic tube compensation, you see the pressure, since it's breath to breath, you see 0.5 centimeters, 1, 2, you see these slight variations.
Yeah.
And of course, automatic tube compensation is not going to extend if the patient maintains the flow above the termination criteria. So the patient can have a 4-second breath technically. The machine's usually shut off by then, but technically the patient can take a giant breath.
Yeah.
And there are some studies that show the work of breathing is different post-extubation, pressure support versus 0 over 0.
And we looked at 242 patients.
We just finished a study like that as well, and the reintubation rate was double on
Right.
5 and 5 versus 0, 0 in our hospital.
Yeah.
Take that for whatever that means, but obviously.
We've got some
Yeah.
experience. Very good. Any very last question before caffeine requirement goes really important?
Water requirement.
Thank you very much. Is there any other means to support weaning for those patients who are difficult or long-term mechanically ventilated other than SPT or like any rehabilitative or
So there's
inspiratory?
loads. Like I can spend like the next hour talking about that because that's what I've been doing for the last few years. But I mean, the main evidence in terms of a trial is Amal Juban's trial where she compared head-on, basically T-piece weaning in an LTAC population. So in an LTAC population, these are the patients that have been in an ICU for at least 3 weeks, stabilised and moved to a different location or within a location of the hospital. And so she demonstrated that using progressive T-piece was more effective in terms of weaning success and duration than pressure support ventilation. So that's the evidence in that patient population. But then, that patient population, it's so much more than the ventilator. The ventilator is the least of your concerns in reality for them.
And just real quick, Dr. Abashi actually kind of developed for his program for weaning, which is to use the ventilator as a trach collar.
Yep,
Or,
absolutely.
and,
that's what we do.
So
Yeah.
you actually use that, set everything to 0, and it's
Yep.
a big fancy, it's got tidal volume, minute ventilation, because fatigue on a T-piece, is way too late.
Yep.
And versus here, you can look at the RISB times the P01,
Yeah.
all those calculations before they are in the bucket.
That's right.
Because
Yeah.
once they desaturate, it's way too late.
Yep. Yep.
Very interesting. Well, thank you very much. Yes, thank you.